So we've reviewed the diagnosis of SMA and its phenotypes. We've talked about the interdisciplinary management that it requires. We've talked about the treatments available, as well as one that is up for FDA approval. Julie, I'd like to start with you and ask what you think would be a take-home message for the community neurologist who may see a patient either with a diagnosis of SMA already or who may be manifesting symptoms that could be attributed to SMA.
There are a lot of messages that I think we can talk about. So I think that the first one is that we have hope and that we have treatments available, which we haven't had in the past, so that making a diagnosis is absolutely critical in this day and age because it leads to the ability to treat. Genetic testing is readily available. The turnaround time is quick. There are genetic testing is free for SMA, so that we really are able and should be able to test any patient to confirm this diagnosis and then move forward with treatment. I think we're all extremely enthusiastic about the opportunities for treatment that we have available now for all age populations. So I think we may have touched on this, but onasemnogene abeparvovec is indicated for children under the age of 2. Nusinersen is indicated for any patient with any type of SMA, with 5q SMA, any age. And hopefully risdiplam, which the trials have gone up to age 60, from infancy to age 60, will, if it's approved, have indication for the general population as well. So I think that there are those treatments that will be available that is very exciting. The other message is that we're not done. And so we didn't talk about some of the ancillary trials that are ongoing, such as Scholar Rock or looking at the anti-myostatin inhibitors. So I think there are add-on therapies that we will have available as well. So my message would be we need to treat patients, we need to treat them early, and that the future is extremely bright for providing care for these patients, that neurologists and pediatric neurologists are vital in the management and the expert management of these patients, but key to taking care of these patients are the primary care providers who will interface with the multidisciplinary clinics to make certain that no matter where a patient is in the United States, that they have access to excellent care.
Absolutely. I think those are great take-home messages. John, are there things that you would add to that?
I think as much as we're all very excited about these new treatment opportunities, sometimes the messaging tends to flip a little bit, especially with gene therapy, where people say, okay, I got my gene therapy, it was early on, now I'm done, I can go live my normal life, which is what we hope may happen if we intervene early enough, but there is still symptomatic aspects of living with SMA in most of the people that are being treated currently. We know that now following the cohort. And there's also a huge unknown to all of this, that these are all very new, and we don't know the long-term durability or the long-term safety of any of these approaches in great detail. So it's very important to maintain that relationship with a specialized care center with people who have expertise in SMA. Sometimes the primary care provider can really help encourage this, because if somebody is generally doing well, they tend to see less motivation for going back to clinic, and encouraging that care relationship is so important to ensure that we're vigilant. And in the case of these treatments that require ongoing therapy, sometimes that's also necessitated by the insurance authorization process and other things, that you continue to collect data to ensure that the authorization continues. So I think there's unique aspects if risdiplam also comes into our armamentarium in terms of the fact that this is a daily medication that you have to remember to take. This is something that's going to lead to all sorts of questions if there are life factors that come up that make that access more challenging. Overall, I would just say that there needs to be an SMA interdisciplinary care team in someone's life if they're living with SMA.
Nancy, any thoughts that you would add to those?
No, I would just really emphasize that the very, very pivotal role that primary care providers have in this, because we have a long way forward to make sure that we're getting very, very prompt diagnoses. So I think that if everyone recalls that there are sponsored free testing, that this is a treatable disorder, and that we should get the testing, particularly in areas where there is not newborn screening, as quickly as people think of the possibility of a diagnosis of spinal muscular atrophy, so it can be either ruled in or ruled out, and then proceed from there. But even in areas where there is newborn screening, we have problems of people living near the edge of a state, and the newborn screening is done by state, so it depends on where the child was born. And so there may be a little bit of, in some communities, a little bit of uncertainty about whether the child has been screened or not. And then, as we already mentioned, there's a very small incidence of false negatives in newborn screening for spinal muscular atrophy, so that if people continue to have clinical concerns, it's important very early to have a plan, a go-to person to ask some advice, and get some evaluation and testing on the child, so we know. All of the studies that we've mentioned and that you've highlighted really emphasize that earlier the treatments started, the better the child does.
We were very good about, I think, trying to address a lot of broad issues during this discussion, but an underpinning of all of this is that there are published consensus care guidelines. So for providers, for primary care providers or neurologists who are not accustomed to taking care of patients who have spinal muscular atrophy, the consensus care guidelines are an invaluable tool for caring for patients with SMA and being able to go forward in a more granular level than we did in this discussion in terms of some of the specifics of providing excellent care as well. So that's a wonderful resource that is available to providers.
Thank you for reminding us of that. This has really been a great discussion. Thank you. On behalf of the panel, we hope you have found this peer exchange to be useful and informative.